Hello, my name is Kristen Smith, and I'm a senior in the nursing program at UNCG. I'm currently completing my 440 rotation in the Trauma Intensive Care Unit at Wake Forest Baptist Medical Center. I will be presenting a nursing-related case study on a 28-year-old female who suffered a gunshot wound to the head and was transferred to Wake Forest Baptist Medical Center via air care. I'm first going to start with some background information on the events leading up to the patient being admitted to the trauma ICU. The patient was found down in her home by emergency medical services with a gunshot wound to her head. The trajectory of the bullet was mainly through the face, resulting in shattering of her right orbit with gross protrusion of her right eyeball. The patient was intubated at the scene due to respiratory distress. She was unresponsive and had a Glasgow Coma scale of 3 in the field, but was found to be moving her right upper extremity upon arrival. Once hemodynamically stable, she was transferred to the Trauma Intensive Care Unit. As far as this patient's past medical history, it includes depression and polysubstance abuse. This patient has no known allergies and is a full code. The patient's history of present illness includes acute respiratory distress, leukocytosis, acute blood loss anemia, hyperglycemia, intoxication with marijuana, subarachnoid hemorrhage with open intracranial wound, traumatic cerebral hemorrhage, history of heroin abuse, orbital fluid blowout or open fracture, bilateral orbital fracture, bilateral maxillary sinus fracture, zygomatic arch fracture, ocular trauma of both eyes, protrusion of eyeballs, trauma to the optic nerve, and metabolic acidosis. The vital sign trends for this patient are as follows. The patient's temperature ranges from 98.5 to 100.4 degrees Fahrenheit. The patient's blood pressure measured 96 to 117 systolically and 63/98 diastolically. The mean arterial pressure was 72 to 105. The patient's heart rate was 90 to 160 beats per minute. The patient's respiratory rate was 14 to 31 breaths per minute, and the patient's oxygen saturation ranges from 92 to 100. Nursing assessment for this patient includes the cardiovascular assessments included normal sinus rhythm and tachycardia, right and left radial pulses were 2+, right and left dorsus pedialis pulses were 2+, capillary refill was less than 3 seconds, there's no clubbing of the fingernails. She has a right arterial line in place, and the site and dressing are both clean, dry, and intact. Pulmonary assessment includes clear lung sounds bilaterally on auscultation and symmetrical chest expansion with no use of accessory muscles. The patient is mechanically ventilated on SIMV with PEEP of 5 and FiO2 of 40%. She has a moderate amount of thin, white sputum when suctioned. The gastrointestinal assessment includes soft, non-tender, non-distended abdomen with no masses. Bowel sounds are present in all 4 quadrants. She has a 16 French orogastric tube placed with 2 feeds at 40 cc's an hour, or a goal of 40 cc's an hour. Foley catheter placed, which is clean and intact with a leg securing device. She is experiencing polyuria. This could be a sign of diabetes insipidus and hypernatremia. Urine is clear yellow with no odor. Skin is cool and dry. There are no rashes, lesions, or ulcerations. Mucous membranes are moist and pink. There is midline facial swelling. The right eye is enucleated, which is the removal of the eye, but the muscles and orbital contacts are still intact. There's a wound to the right temple with stitches intact, wound to the left side of the head with stitches intact. They are both clean and dry. The neurological assessment was ordered for every hour. Glasgow Coma scale of 6, which was higher than what she had originally presented with. This tells me that there is a definite head injury at this time. Her pupils are unable to be assessed. Her right upper and lower extremity strength is 2+, and left upper and lower extremity strength is 3+. She has generalized weakness and follows some commands. She has soft extremity restraints ordered bilaterally due to her trying to dislodge lines in tubes. Medications that this patient is currently on and scheduled to receive are as follows. Brimodifine or alphagen eye solution, 1 drop 4 times a day into left eye. This is used to reduce the pressure in the orbit. Chlorhexidine or Paradex, 15 milliliter 2 times daily in oral swab. This is to prevent bacteria buildup inside the mouth. Since she is on the ventilator, she is at risk for pneumonia, and this medication can help decrease that risk. Erythromycin eye ointment, 2 times daily in both eyes. This is a topical antibiotic used to prevent and treat infection that may be present. Insulin, regular sub-Q injection on a sliding scale, 2 to 8 units, 6 times daily. This is used for hyperglycemia. Her blood sugars are higher since she is in the hospital and has experienced a traumatic event. Synthroid, 50 micrograms oral tablet, once daily. This is used for her endocrine complications related to pituitary damage and to increase her sodium levels. Miriam, 2 grams IV piggyback every 8 hours. This is an antibacterial medication used to treat infection. Reglan, 4 times daily per OG tube. OG tube. This is used to treat nausea and vomiting. She has not been tolerating her tube feeds well the past 5 days and did vomit, so this is used to decrease that. Flagyl, 500 milligrams IV piggyback every 8 hours. This is an antibiotic used to treat the diagnosis of C. diff. She acquired this after being admitted to the hospital. Propranolol, 5 milligrams oral 3 times daily. This is a beta blocker used to lower her blood pressure. Zantac, 150 milligrams orally 2 times daily. This is used to prevent the tube feedings from causing esophageal reflux. Redomifin, 600 milligrams twice daily via IV. This is an antibiotic used to treat infection. Redomifin, 600 milligrams once daily via IV. This is an antibiotic used to treat infection. Synacot, 17.6 milligrams orally 2 times daily. This is used to treat constipation. Vancomycin, 1.5 grams IV every 12 hours. This is an antibiotic used to treat infection. The continuous infusion this patient had ordered are 0.9 sodium chloride infusion, 30 milligrams per hour IV. This is her maintenance fluids. PRN medications that this patient had ordered are acetaminophen or Tylenol, 650 milligrams every 4 hours orally for fever over 101.5 degrees Fahrenheit. Fentanyl, 20 to 55 mics every hour IV, 25 for moderate pain and 50 for severe pain. Oxycodone, 5 to 10 milligrams orally every 3 hours, 5 for moderate pain and 10 for severe pain. Now that the background information, assessment, and medications has been covered, I'm going to go in depth about each concept and relate them to the nursing process. Her fluid and electrolyte balance showed that her sodium was 136 and had been ranging in the upper 150s, and 200 milliliter of free water was given to lower her sodium levels. The cause of this was possible pituitary damage and endocrine dysfunction that was unknown at this time. Her potassium was 3.7. Chloride was 110. Calcium was 7.7, which is high and related to possible endocrine dysfunction as well. Her blood urea nitrogen was 10. Creatinine was 0.41, which is a low, but not a cause for concern. Her urine-specific gravity was 1.013. Blood glucose was ranging from 90s to 250s. Regular insulin was given, and a continuing nursing action would be to check blood glucose levels every 6 hours and administer the correct dose, which should result in blood glucose levels normalizing. Her hemoglobin was 7.2 and her hematocrit was 26.5, which both of these are low, and this resulted from her acute blood loss anemia. Her pH was 7.27. Her PCO2 was 44.9. Her O2 was 74. Her bicarb was 20.8. This revealed that the patient was in metabolic acidosis. Nursing interventions included monitoring vital signs, assessing for any changing in neurological status and respiratory status, Marked dehydration may be present, so monitoring her intake and output is essential. The patient outcomes I would hope for was to be free of symptoms of imbalance and her vital signs to be within normal limits. The patient's urine output spiked overnight, and the endocrinologist expected pituitary damage and diabetes insipidus toggling with SIADH, which is syndrome of inappropriate antidiuretic hormone. She was ordered to receive DDAVP to help maintain serum sodium levels. The nursing diagnosis related to this problem would be imbalanced fluid volume status related to brain injury as evidenced by critical lab values. Continuous nursing interventions would be monitor fluid status, give the scheduled medications, and monitor serum sodium and other electrolytes. And be sure to report any changes to the physician because this could mean a decrease in cardiac or renal perfusion. I try to reposition her every 2 hours to maintain good tissue perfusion. I kept the head of the bed in Fowler's and continuously monitored O2 saturation. The patient tolerated intervention with no decline in status. Since this patient had suffered a penetrating trauma, she was started on the antibiotics vancomycin and flagyl at very high doses. The patient has been diagnosed with C. diff and is on contact precautions. Her white blood cell count is 30.8, which is indicative of an infection. The nursing diagnosis I gave her is at risk for impaired skin integrity related to accumulation of waste products. Nursing actions related to this problem is to adequately assess the skin for pallor, redness, and breakdown. Keep the patient's skin clean and bed linens dry and wrinkle-free. The patient maintained tissue integrity as evidenced by no skin breakdown and absence of any redness. Other potential nursing problems related to this concept identified is increased risk of infection related to intubation, intravenous access, arterial line access, and her indwelling urinary catheter. Nursing interventions included assessing for any increase in sputum, increase in temperature, and also providing mouth care with her prescribed chlorhexidine solution to reduce the amount of bacteria inside the mouth and throat. I made sure to pause tube feedings when I lowered the head of bed to decrease the risk for aspiration and acquiring ventilator-assisted pneumonia. I assessed for declining changes in mental status and malodorous and cloudy urine for presence of a UTI. As far as outcomes, I would expect the patient to remain free of infection as evidenced by normal vital signs and absence of these infections. Continuous nursing interventions to keep the patient infection-free is to wash hands before entering the room, provide adequate mouth care every 2 hours, keeping IV sites clean and in date and dry, giving the prescribed antibiotics. By doing these things, we hope that the patient does not contract any other infection and the white blood cell count lowers with administration of these antibiotics. As far as hemorrhagic versus clotting, the physician ordered to hold all anticoagulant and antiplatelet because of the given head bleeds. The patient's PT is 12.0, INR is 1.26, PTT is 27.5, and platelet count is 263,000. The clotting factors were within normal limits. I assessed for peripheral pulses, edema and extremity pain, increasing respiratory problems, skin temperature, and monitored vital signs. However, a potential nursing problem related to this concept would be ineffective peripheral tissue and perfusion related to decreased venous circulation as evidenced by weak or absent peripheral pulses. Nursing actions included turning every 2 hours, applying SCDs, performing active range of motion, and elevating legs with slight knee flexion. The patient demonstrated adequate tissue perfusion as evidenced by warm and dry skin, capillary refill of less than 3 seconds, adequate urinary output, and the absence of increasing respiratory distress that would be indicative of a clot. As far as oxygen and perfusion, the patient was intubated and on a ventilator. She was on SIMV with pressure support of 10 and PEEP of 5. Her FiO2 was set at 40% and her respiratory rate was 12 breaths per minute. Her ABGs, as I stated earlier, were indicative of metabolic acidosis. Her hemoglobin and hematocrit were low, so the oxygen carrying capacity of the blood was not adequate because she had lost so much of it. The values were not low enough to require a blood transfusion, but continued nursing actions would be to obtain those labs when ordered and to ensure that they did not fall any lower. A nursing problem identified to this concept would be impaired spontaneous ventilation related to altered oxygen carrying capacity of the blood and mental impairment as evidenced by inability to move secretions. Nursing actions to maintain would be to maintain ventilator settings, assessing and documenting respiratory rate, vital signs, oxygen saturation every 15 minutes, and to ensure to catch any increasing respiratory signs of distress. I also suctioned as needed for no more than 10 seconds to maintain a patent airway and to improve ventilation. I made sure that the endotracheal tube was secured, had enough slack, especially when turning the patient, and was constantly at the correct measurement. I kept the head of the bed in Fowler's position at all times, with the exception of turning the patient. I was sure to pause tube feedings when the head of bed was down to prevent aspiration. The patient maintained optimal gas exchange as evidenced by no further reduction in mental status. As far as mobility and alignment, this patient presented with reduced muscle strength and limited range of motion in all four extremities. She was bedridden due to being on a mechanical ventilator and trauma. A potential nursing problem would be at risk for pressure ulcers related to immobility. According to an article that I found on pressure ulcers in the ICU, identifying patients who are at risk for developing pressure ulcers is the first key in determining the appropriate strategies to prevent pressure ulcers and to improve the quality of care for patient safety and ultimately to reduce the stay in the hospital. So after realizing that this patient was at risk and giving her the adequate nursing diagnosis for pressure ulcers, my nursing actions to prevent pressure ulcer development including turning and repositioning every 2 hours with pillow and wedges, changing the linens when they were sold, keeping them clean and wrinkle-free, performing range of motion exercises every 4 to 8 hours and using barrier creams and powders when necessary, and elevating the heels off the bed. The patient's skin remained intact as evidenced by no redness or breakdown over bony prominences. As far as nutrition and elimination, this patient had an orogastric tube placed with a tube feeding goal of 40 cc's an hour. Currently it was going at 30 cc's an hour and she was tolerating it well. She was also receiving 200 milliliter of free water every 6 hours and is receiving Zantac for acid reflux. Her serum albumin level was 2.9, her protein level was 4.6. This told me that her nutritional status was inadequate. Her last bowel movement was earlier in the day and it was a moderate amount of thin, loose, watery brown stool. The patient had a Foley catheter in place with clear yellow output of more than 30 milliliters an hour. A nursing diagnosis I gave her related to this concept was altered nutrition less than body requirements. A goal for this patient would be to maintain proper nutritional status of the client. Continuous nursing interventions included maintaining ordered tube feeding in free water, keeping the head of bed at 30 degrees, and flushing tube after medication administration to prevent occlusion of the tube, measuring and documenting gastric residual, ensuring the placement of the tube, and also keeping the area clean and dry. The patient tolerated tube feedings at this time. This patient could not verbally express pain, so I had to use the behavioral pain scale, which is, I have it demonstrated here. This included facial expressions, upper limb movements, and compliance with mechanical ventilator. As you can see here, the 3 different items that it goes over. I gave her a 9 based on the behavioral pain scale, which required nursing interventions. The nursing problem identified was pain resulting from trauma, as evidenced by a behavioral pain score of 9 out of 13. Ongoing nursing interventions included observing and monitoring for signs and symptoms associated with pain, such as blood pressure, heart rate, temperature, color and moisture of skin, restlessness, and facial grimacing. I also provided rest periods to facilitate comfort and sleep and relaxation, and gave the prescribed pain medications. I gave the PRN medication oxycodone 10 milligrams orally for severe pain. I reassessed the patient's pain via behavioral pain scale response. After 1 hour of administration, the score was 4 out of 13, and the patient demonstrated the expected outcome of decreased pain. Continuing nursing actions involved assessing pain every 2 to 4 hours and giving the scheduled medications when indicated. According to Erickson's stages of psychosocial development, this patient is in the stage of intimacy versus isolation. She has a medical history of depression, social history of drug dependence and abuse, which includes heroin and marijuana. We are not sure if the gunshot wound was self-inflicted or not, but after talking to the patient's family, they state that that is a possibility. This tells me that she is not developing like others in her stage, and I would categorize her in the isolation stage. Now that this trauma has happened, her life will not continue to be the norm like others her age. Nursing diagnosis I would give her as ineffective individual coping related to situational crisis, as evidenced by depression and altered social participation. Nursing interventions included verbally comforting this patient, reassuring that this patient is safe, updating her on her care in the hospital, and when the time is right, I will discuss with the patient different coping techniques. An outcome would be that by discharge, this patient will report an increase in sense of control over her current situation. As far as interdisciplinary care, this patient did require procedures in collaboration with many other healthcare providers. This patient had an arterial line placed, which required dressing changes twice a week. I informed her that this needed to be done to decrease the risk of infection. As the nurse, I informed her that she needed to keep her arms still and that she would feel some tape being pulled from her skin. She also required suctioning as needed related to increased secretions. I informed this patient that this would clear the secretions in her smaller airways. I informed the patient that she may feel the need to gag or cough, and that was okay, and to expect a little bit of discomfort. I would hyperoxygenate her with 100% oxygen and insert the catheter in her trachea by manipulating it through the plastic shield to provide sterility, and apply suction when pulling out the catheter in a circular motion for no more than 10 seconds. The patient tolerated this well with no drop in O2 sats or heart rate. The patient was a glucose check every 6 hours. So every 6 hours I would perform a finger stick on the patient and take the patient's blood to check the glucose levels. I made sure to tell the patient that she was going to feel a small prick and then press her afterwards. The patient tolerated this well by no signs of distress. As a nurse, I had to work closely with other care providers and be the patient advocate when it comes to making decisions about this patient's care. As a nurse, I spent most of the time with this patient, so giving each care provider the most accurate and up-to-date information was very essential. I was quick to update on status changes and document any deviations from baseline. For example, her wound on her right temple was bleeding through her dressing, which was a change in baseline from earlier in the day. I consulted with plastics since they had inserted the sutures earlier. Also, neurosurgery ordered for her to have a pressure dressing over her right eyeball and to assess every 6 hours. I applied the pressure dressing and notified that the swelling did decrease after 6 hours. This patient was being seen by endocrinology, plastic surgery, infectious disease, neurosurgery, trauma physicians and residents, ophthalmology, dietitians, social workers, x-ray technicians, and respiratory therapists, so collaboration with other care providers was definitely evident. This concludes my nursing case study and covers all the evident critical concepts. Thank you for watching.